Next, neuromodulation. What is neuromodulation? To understand the concept of neuromodulation, it is necessary to provide some relevant background on neuroscience as a whole. Firstly, as elaborated in Elliot Wallenstein's book, neuroscience has been somewhat polarized historically between those who have studied the brain from primarily an electrical viewpoint, that is, the sparks, and those who have considered it from a chemical viewpoint, the soups. At the risk of oversimplifying this, nerve cells do not only communicate with each other by means of electrical impulses transmitted over sequential nerve cell junctions or synapses, which would then be the electrical signals or sparks, but they also interact by releasing and responding to a wide range of neuroactive chemicals, or chemical signaling, and soups. These influence or modulate their responsiveness and behavior in relation to the impulses, and how they form long-term connections. Only quite recently have advances in neuroimaging techniques allowed these neuroactive chemicals to be studied within the living, functioning brain. Prior research had focused almost exclusively on the structural and electrical components, so at present, neuroscience is in a major process of revising many of its theories in an avalanche of emerging data. Secondly, also until relatively recently, it was believed that the number of brain cells was largely fixed at birth, and, if lost, could not be replaced. Consequently, it was also believed that peak mental abilities were somewhat predetermined, and that brain injuries were unable to heal. Any functional recovery was attributed to reorganization and adaptive reconnections amongst remaining living brain cells. The possibility of forming new brain cells was effectively ruled out. Research has since shown that not only can brain cells actually reproduce in response to injury or changing functional needs, but also that neuroplasticity, which is in a sense functional brainscaping, has far greater potential than was recognized previously. The combination of these two shifts in neuroscientific paradigms has sparked various new approaches to dealing with mental dysfunction and even structural damage to the brain. One of these approaches is called bioneurofeedback, or neurofeedback for short. The common goal is to enhance and guide the process of recovery and functional brainscaping in more effective, target-driven, and objectively guided ways. So what is bioneurofeedback? Well, perhaps the best explanation would be to start with a familiar illustration, the way we use a mirror. When combing our hair in a mirror, we make use of the reflected image to guide or modify our actions. The mirror image is not an exact replica of reality, it is a reversed image, but our minds learn to process that information to achieve the objective, grooming. And that is essentially what bioneurofeedback does. It reflects bioelectrophysiological data from our bodies, which in turn prompts the brain to adapt. Only in this case, the idea is to straighten the mind rather than the hair, and we use a computer interface and scalp electrodes rather than a mirror and comb. In a previous section on neuroimaging, we reviewed the basic concepts of brain electrical activity mapping, or quantitative EEG brainwave measurement, which is a non-invasive record of electrical activity in the brain. Unlike traditional EEG, which has been used mainly to screen for and diagnose seizure disorders, modern beam or QEEG is being used increasingly to identify brain and mental disorders, as well as developmental disorders in children, such as autism spectrum disorders. It does so, firstly, by measuring the range of brain waves through the scalp, and then using various electrical filters and algorithms processing this information to determine the most likely points of origin and relative distribution throughout the brain, as well as identifying the associated networks or functional connections between parts of the brain. Brainwaves are, broadly speaking, divided into frequency ranges from less than 1 to 70 or more cycles per second. Each of these functional ranges were assigned a letter of the Greek alphabet in the order their relevance was discovered, which is also why they're not labeled chronologically from the lowest to the highest. Oversimplistically speaking, each frequency range represents a distinctly different mental state, or level of wakefulness. by analyzing each of these frequency ranges in turn, and then using colors to label their respective intensities and distribution across various brain regions, a brain map is produced. These maps can then be compared to large databanks of normal and abnormal data. Again, in simple terms, the lower the brain wave frequency, the lower the level of mental activity, either in general, if it is a predominant pattern throughout the brain, or regionally, if it is the predominant pattern in a certain part of the brain. By extensively studying various mental states, as well as patients with different mental disorders, it has become possible to identify typical patterns of what is normal and abnormal. This allows not only the recognition of abnormal mental states, but also, and even more usefully, it predicts with significant accuracy which interventions are most likely to be helpful in restoring the patterns to normal, whether through the use of medication or bioneurofeedback. As an investigative tool, BEAM or quantitative EEG data only shows potential abnormalities. It's not interactive in this diagnostic configuration. In this form, it's a bit like a static photograph rather than a dynamic interactive mirror. In other words, a computer-brain interface still needs to be added. By setting this up, using computer software to bracket the ideal range of EEG signals in those areas of the brain where they were found to be lower or higher than normal, and then rewarding the person undergoing training when these ideal brainwave states are achieved and maintained, the brain soon discovers what the objective is through the reward feedback system, and then eventually learns to maintain it spontaneously long term. The reward takes on the form of either computer game actions, specific sound cues, or simple go-stop interaction with a movie or soundtrack. The changes are often achieved within 15 to 25 30-minute sessions over 6 to 12 weeks in less complicated cases. Now, in terms of using bioneurofeedback for traumatic disorders, the pioneer in this area was Eugene Penniston. Penniston found in a series of war veterans suffering from various post-traumatic problems, including alcoholism, that when he was able to reward their brains to remain between alpha and theta brainwave states, spontaneous resolution would occur through various forms of abreaction imagery. It seemed that this would allow the traumatic barriers to be overcome within the safety of a clinical setting. However, as mentioned in the section on hypnotherapy, this should not be initiated until there has been stabilization and the therapeutic relationship is strong enough to deal with the material that is uncovered. Although I'm not personally involved in this form of therapy, this is a model I've often used to conceptualize it for people who ask me about it. The features associated with each frequency spectrum, from delta to gamma, represent, at least philosophically, a kind of spirit-soul-body continuum. Given this framework, alpha-theta crossover would then represent the electrophysiological signature at the junction between the subconscious or spirit and the conscious or soul state. By bracketing this as an objective target and then indicating to the subject when it is reached, the whole process becomes far more scientific than randomly using psychoactive medication or hypnotherapy. Also, the process of neurofeedback is completely non-invasive and fully controlled by the subject, not by the therapist. The individual undergoing this process has complete freedom to disengage at any time point. Having said that, this does not mean it can be offered by non-professional or unqualified individuals. The traumatic images, memories, or other abreactions will require appropriate management. So the goals and precautions remain the same. It's only that this tool is very objective and more refined than some of the alternative techniques. A slightly modified alpha-theta protocol has actually been applied successfully in dissociative identity disorder, as shown in this article. Still, generalizations are not possible at present, and the phase-oriented timing of these interventions, if they are used, remains a central caveat. I should also hasten to say that alpha-theta training is only one form of neurofeedback. There are various other brain wave training targets depending on the type of mental dysfunction. for instance, attention deficit, obsessive-compulsive, bipolar, and depressive conditions, each of which have distinctly different targets and protocols. So this is not a comprehensive review of the topic. For a slightly dated but very accessible introductory overview of the background and application of QEEG and neurofeedback, I recommend Jim Robbins' book, A Symphony in the Brain. The last section of this series is on partnering between individuals in need of help, health professionals, and supportive people and communities. In practice, these partnerships take the form of multidisciplinary teams, family therapy when indicated, self-help groups, professionally guided group therapy, and supportive communities of faith. All are relevant, but only the last will be addressed within the scope of this presentation. The role of communities of faith in terms of their supportive engagement with a dissociated individual and with the health professionals who assist them is absolutely crucial. It is also potentially very problematic. There are many reasons why cooperation between healthcare services and communities of faith can become complicated in supporting individuals with dissociative disorders. Most of the difficulties arise from the differing nature of the relationship, professional and compensated therapy versus pro bono and voluntary affiliation, the differing worldviews, that is, scientific or materialistic versus spiritual, the different theories on the underlying nature of the problem and therefore the best solution, psychotherapy and medication versus conversion, deliverance, or exorcism. And also because individuals with dissociative disorders can be quite demanding and challenging. Not only do they not necessarily have the skills and experience to maintain wholesome relationships, but these skills and levels of maturity may vary greatly with their respective mental states. As such, the relationship they have with others, especially within a religious setting, may easily become codependent, confusing, or condemnatory. Again, without proper understanding of the condition itself, other explanations are likely to be imposed, and these most likely will not foster greater support. So sadly, as a result of these differences, it is not unusual for individuals with dissociative disorders to ultimately be forced to choose between their communities of faith and the therapy they need. This is tragic. It is analogous to having a hospital instead of a home. So it is vital for spiritual leaders and members of communities of faith to have a better understanding of the disorder. They should also have realistic understanding of their own role and the necessary boundaries to fulfill that role. Dissociative disorder patients do need unconditional love, but they also need patient parenting as they experience the necessary safety to become more integrated. A major part of the difficulty surrounding dissociative disorders, especially within the context of communities of faith, is the understanding of spirit world realities and the distinction between possession or oppression and fragmentation, as we discussed at length in the first section of this series. Psychiatry also acknowledges this difficulty as seen in this article. The author's conclusion, though, is particularly encouraging in this regard. So the challenge is to provide a framework in which it would be possible to collaborate in humility rather than to polarize in arrogance. For the purpose of getting on the same page, this article in the Hong Kong Journal of Psychiatry offers an excellent overview of the historical, religious, and medical perspectives on the possession phenomenon. It also attempts to characterize those features where spiritual agencies might quite rightfully be suspected, with the implication that, when these are not present, fragmentation and dissociation should first be given the benefit of the doubt. The matter is obviously more complex than this. Those professionals and spiritual leaders who have significant experience in helping dissociated individuals, especially those coming out of extreme religious or satanic ritual abuse, will readily admit this. However, a default position of acceptance and inclusion, rather than rejection or banishment, will afford these people a greater chance of recovery, irrespective of the cause. Obviously, the safety of both the affected individuals and the members of the community must be assured. As such, the emphasis should be on trust and teamwork. It is not everybody's cup of tea, so to speak, but it is an extraordinary opportunity for communities of faith to fulfill one of their core common objectives, demonstrating and fostering the fullness of what it means to be a loving, supportive human family. I want to close by directing you to some resources that may be of value in facilitating participation and collaboration. The Dissociative Identity Disorder Sourcebook, published by Deborah Haddock in 2001, is written in very accessible language by a credible therapist in a way that's appropriate for patients, therapists, and also for individuals working with or living with those suffering from dissociative disorders. It has been discussed in detail early in this series and establishes a good foundational understanding and common language. This book on connecting the fragments discusses the complexity of supporting individuals with dissociative identity disorder within the context of the Christian Church. Many of the principles could be generalized to other communities of faith, however. It also offers very helpful approaches towards achieving collaboration. It is appropriate for health professionals, spiritual leaders, individuals with dissociative disorders, as well as members of the communities of faith who wish to participate in providing support. These two books, in my opinion, are only appropriate for professional therapists or recovered survivors of ritual abuse. The material is transparent, very graphic in places, and I would not recommend it for entry-level readers or for persons with existing dissociative disorders, and certainly not at the initial stages of therapy. It is written largely from a secular perspective, although there is a lot of material, some of which is quite disturbing, on how communities of faith can actually be part of the problem rather than part of the solution. Healing the Unimaginable is written by an experienced therapist, whereas The Enslaved Queen is an autobiography written by one of her patients. There are also books that are more generic in terms of how-to for health professionals who want to partner appropriately with the spiritual care of their patients. Spirituality in Patient Care by Harold Koenig is an excellent overview of why, how, when, and what to deal with in spirituality and patients. It covers various persuasions of faith and explains what to avoid in simple language. For those interested in actually seeing how mind-body connections are expanded into the spiritual arena and seeing the actual physiological mechanisms associated with it, the link between religion and health is an excellent starting point. Edited by Cohen and Koenig, this book is based on a workshop at Duke University in 2000. It includes a large number of studies on survival, cancer, immune function, and mental health in relation to spirituality and religion. If you are looking at healthcare partnerships within a community of faith, these are also some very useful resources. I would also like to actively encourage individuals, particularly in the nursing profession, to consider the possibility of such partnerships. Parish nursing is one such example. Various communities of faith are employing nurses to look after the welfare of their congregations, and new models for partnering continue to develop. Some are more healthcare-oriented, whereas others are more community of faith-oriented. These all represent an extension of the heart of healthcare. The impact of religion and spirituality on biological realities has been notoriously difficult to document. However, over the past 3 decades, many thousands of articles have appeared in reputable journals, and these have been examined in several publications. Faith and Mental Health is a very accessible version of the role of communities of faith in mental health. The other book, Religion and Spirituality in Psychiatry, offers a scholarly review of the whole topic of religion and spirituality from various perspectives in terms of the implications on psychiatric practice. Additional resources of this nature include Spirituality, Religion and Faith in Psychotherapy by Helen Land, as well as Spirituality and Psychiatry by Chris Cook et al. And lastly, these 2 editions of the Handbook of Religion and Health, published in 2001 and 2012 respectively, review 1,200 studies and 400 reviews on religion and health prior to 2001, and 2,800 and more scientific publications between 2000 and 2010. This concludes the overview on dissociative disorders in medicine and psychiatry. It is my hope that this presentation will actively encourage greater openness, clarity, and dialogue between those individuals in need of help and those willing to provide it.